Well, first of all, the whole business of developing a risk calculator is a risky business. The problem with risk calculators is that they're based upon the available data at the time that the risk calculator is developed. But often the data is 5, 10, 15 years old. Well, it turns out with many of the public health measures, the use of better blood pressure lowering medications and other factors, these risk calculators are imperfect. And the pooled cohort equations, which were used in 2013, many of us thought were flawed right from the very beginning, and they've gotten more and more flawed as time has gone on. And so you're seeing a kind of backing off on the idea that that risk calculator is the be-all and end-all, and more of a recognition that we need to think about these things, and we need to look at these other factors, like family history and like the presence of other risk factors that are not in those calculators. For example, inflammatory risk, high levels of C-reactive protein, something that I think is a very important factor in deciding who to treat. Well, they're now in these new guidelines, and so there's a moving away from the idea that that risk calculator should be an absolute standard. It's really just a rough guideline about who should be treated and who shouldn't. We have to use common sense and good clinical judgment. Well, I have only one major disagreement with the guidelines. There is advocacy for coronary calcium scanning as a way to decide who to treat in those people that are intermediate, it's not clear one way or another to treat. And I do not favor this approach. This means using a test that involves giving patients radiation that can be fairly costly in order to decide whether to give a drug that can cost as little as $3 a month. I don't think it's cost effective. I don't like the idea of exposing people to unneeded radiation. And so I would argue that the advocacy for calcium scanning is an area that I'd like to see change. Now, interestingly enough, the guideline writers in their press conference really soft-pedaled the idea of calcium scanning. They backed off quite a bit in the way they presented this to the media, and I agree with that. I think it's a test that's overutilized and may in fact lead to unintended consequences. So that's an area that I would like to see changed. Perhaps one other area of controversy. The guidelines for the first time talk about the cost effectiveness of medications like the PCSK9 inhibitors. And the problem with addressing cost effectiveness in the guidelines is that it's a moving target. You know, the prices, for example, were recently dramatically reduced by about 60% for the PCSK9 inhibitors. Well, if you put a calculation into the guidelines about cost effectiveness that's based upon pricing that's no longer the actual pricing, you're going to actually give erroneous advice. I would have preferred if they had not addressed price in the guidelines. I think guidelines ought to be about science, and then, patients, providers, insurance companies, everybody else can talk about the cost issues.